La siguiente presentación está a cargo de un excelente neurólogo que viene de la ciudad de Phoenix, Arizona. Él es un pionero y experto en un tema que cada vez está causando o está siendo cada vez más predominante en el estudio y en el diagnóstico de los trastornos del movimiento, tanto para enfermedad de Parkinson como para otras enfermedades degenerativas como el Alzheimer. El tema que vamos a hablar ahorita es sobre biomarcadores en el diagnóstico de enfermedad de Parkinson y posiblemente veamos algunos otros puntos relevantes. El doctor Levine, Todd Levine, es un médico de renombre a nivel mundial, múltiples publicaciones y la verdad para nosotros es un verdadero honor y un privilegio contar con su asistencia en este curso. Doctor Levine.
So, thank you for having me here, my first time in Saltillo, and happy to give the presentation. I thought what I would do is talk a little bit about kind of where the field is now with using biomarkers in helping diagnose the neurodegenerative diseases. So I'm going to go through just what we think about when we say something is a biomarker, then talk about some blood tests that are available now, talk about something called the seeding assay, and then talk about a test that I've done a lot of research on called the SYN1 test. So a biomarker can be one of two things. It can be something that we find clinically that allows us to understand that patient in a better way. So understanding their biology or their pathology. It can also be used if we're going to intervene and we're going to try to treat that patient. So we can see if there is a response to therapy or if the patient is reacting the way that we want them to react. Typically though, these days when we talk about biomarkers, we're now talking about some type of molecule that you can identify, and it could be in any tissue or blood or spinal fluid. But that molecule then has an association with the disease or the disease process. So biomarkers don't have to be a test. It can be something that we see in the clinic, but we're going to talk more today about it as being a test. The earliest biomarkers in the neurodegenerative diseases were really molecules that we could identify in the spinal fluid. So on the left side of the screen are the different types of molecules that people have studied as being valid biomarkers. Probably the most well-known are those associated with Alzheimer's disease. So amyloid, the A-betas, and the tau proteins. But we also now know of one in particular called GFAP, for glial fibrillary acidic protein. We talk about the neurofilaments. And what's really changed is with better sensitive tests, we now can look for many of these proteins in the blood. So a much more readily accessible way to get to these proteins than having to look into the spinal fluid. And much of this has been done now with the development of the mass proteomics that we've seen used in a number of research studies. So I want to talk first about, I think, one of the best well-established proteins that we can look for in blood, which is called neurofilament light chain. And the neurofilaments are structural proteins within the axons, and we have a light chain, a medium chain, and a heavy chain. The one that's really gotten the most sensitive results has been focusing on the neurofilament light chain. So we're going to talk about neurofilament light chain. And where this has really been of interest is in patients that have motor neuron disease. And so the idea is that if something is damaging the axons, then these proteins are going to leak out into the bloodstream. They're very nonspecific, so it doesn't necessarily tell us what is damaging the axon, but it tells us that there is ongoing damage to the axon. So it's been studied in a number of diseases, Lou Gehrig's disease or ALS, probably the most common, but it's also been studied, for example, in multiple sclerosis as a way of following someone's ongoing therapy. So if they're on therapy for their MS and the therapy is working, the neurofilament light chain goes back to normal. Even in the absence of discrete exacerbations, if the disease is still active, we can see that the neurofilament light chain is actually elevated. So many people talk about it as being sort of a sed rate, a sedimentation rate for the nervous system. It tells us whether or not there's something that's actively going on. But in patients with ALS, there are very high levels of neurofilament light chain. And so this has been used to aid in the diagnosis if you're trying to distinguish someone who has ALS from other types of nerve diseases or central nervous system processes. It's also been shown that you can track the progression of somebody's ALS. So if you look at a person, if you look at the bottom graph, in the red, you see someone who has elevated very high levels of neurofilament light chain, and their disease progresses much more rapidly. If somebody has marginal or just mildly elevation in their neurofilament light chain, then their disease is going to progress more slowly. So not only can it help in the diagnosis, it can also help in the prognosis in terms of tracking somebody. And this got a lot of attention because if we're going to intervene with pharmaceuticals, we want to have a test that can hopefully tell us very quickly whether or not a patient is going to get better. So this is a comparison between the neurofilament light chain, in patients, as well as just the ALS functional rating scale. And the neurofilament light chain actually performed better than the clinical outcome in predicting response. Here you can see in the yellow are patients that are slow progressors with ALS, in the orange are fast progressors, and then in the red are patients that have the C9orf72 mutation who are very fast progressors. And you can see that the level of neurofilament light chain goes up the more the patients are progressing. Now, where this has really taken hold is then in using this to detect pharmaceutical responses. So here was a trial of using an antisense oligonucleotide in patients that have the SOD1 mutation for ALS. And what you can see in the red is that as patients started therapy, their neurofilament light chain levels went down. In blue are patients on placebo. And then at the dotted line, the patients on placebos switched over to the active arm, and you can again see their neurofilament light chain drop down. And this correlated with the patient's response to therapy as well. And here again, very similar looking at the neurofilament light chain in these patients. And this was actually one of the first times, or the first time that the FDA in the US relied on neurofilament light chain to approve a drug, because the proof was so strong that the amount of disease damage was going down with therapy, that this drug actually got approved for use in patients that have the SOD1 mutation for ALS. Okay, so what about in Alzheimer's disease? So again, a lot of interest in using blood-based biomarkers, not just spinal fluid biomarkers, to aid in the diagnosis of Alzheimer's disease. And the two, I think the two that have the most evidence right now, one is looking at the ratio of A-beta 42 to A-beta 40. And that gives us about an 86% accuracy in looking at that ratio in the blood. But on the right, you see the newest test, which is called p-tau. So this is the phosphorylated form of tau, and in particular, the phosphorylated form of tau at the residue 217. So we call it p-tau 217. And this has very high accuracy for a diagnosis of Alzheimer's disease, greater than 90%. This actually compared patients' PET scans to the different types of biomarkers. And so you can see that plasma levels of p-tau 217 had over a 96% accuracy in correlating with the PET scans, indicating that a simple blood test actually has the same degree, if not better, accuracy as using PET scans. And so this has now, in the US, begun to really replace the use of the amyloid PET scans in a lot of clinical trials. And this actually looks at again, the p-tau 217 compared to the other biomarkers, either neurofilament light chain, the p-tau 181, which is another residue, and then MRI scans looking at atrophy. And you can see that the curve on the left has the highest area under the curve, which is that associated with p-tau217. So this is now really a very accurate biomarker for the diagnosis of Alzheimer's disease. So what do you want from a biomarker if you're going to use it? Well, number one, you want the accuracy. So you want to know that if the biomarker is present in your patient, it's going to predict the likelihood of Alzheimer's disease. But like with neurofilament light chain, you also want it to have some prognostic value. And so what this is really showing us is at the higher level of the p-tau217, the worse their cognitive scores are and the worse their progression is going to be. So it does have both diagnostic implications as well as prognostic implications. So these two blood tests, the neurofilament light chain and the p-tau217, have really begun to be much more widely used and actually are fairly affordable too, which is the other big advantage of the blood test compared to imaging studies. This got a lot of attention last year. So in JAMA Neurology, there was a big article talking about the seed amplification assay. So I want to go through this. Now, this is primarily used only on spinal fluid. There have been some research studies using this on blood, but primarily it's a test that's used in spinal fluid. And when we talk about seed amplification assays, we're talking about a number of different tests that go by different names. So one is PMCA, one is RT-QuIC, which stands for real-time quaking-induced conversion, and then Hanabi is another. And these all came from the discovery of the prion proteins. So with prion proteins, we know that this protein is infectious and it will cause other proteins to misfold. And so what people developed was a test where they would take a sample from a patient, they would expose it to the normal protein, and then by just slowly shaking the proteins together, we see whether or not the patient's sample causes the proteins to fold incorrectly. So that's how we diagnose Jakob-Creutzfeldt disease, by doing this type of a test. We took this now to also look at alpha-synuclein. And so we're going to talk a bit about alpha-synuclein with the rest of the talk. In general, though, they all rely on the ability for the patient's sample to cause the normal protein to misfold. And that's what we talk about when we talk about a seed amplification assay. So the idea is you have seeds. The seeds are the normal protein. You have the monomer, the seeds of the patient's protein. You have the monomer, which is the normal protein. And you put them together into this lag phase, and you expose it to something called thioflavin, which allows it to fluoresce as it misfolds. So you have these endogenous seeds. They're incubated with the recombinant human protein. And then as you leave the lag phase, you get into this exponential phase where the proteins are going to misfold. That process actually takes days. So they're sitting in this analyzer for days as we watch the proteins misfold. And then what we're looking at is as we hit this plateau phase, we've consumed all of the monomers, and we're going to look at how much fluorescence there is. Now, the seeding assay actually can be different depending on the type of abnormal synuclein that you're exposed to. And so one of the easiest comparisons to look at here is Parkinson's disease versus multiple system atrophy. In Parkinson's disease, you have the normal alpha-synuclein. That alpha-synuclein then starts to misfold into fibrils and eventually forms the Lewy body. In multiple system atrophy, the fibrils actually form in the glial cells and cause cytoplasmic inclusions. So the type of misfolding is actually different between Parkinson's and multiple system atrophy. And therefore, using the seeding assay turns out to be very sensitive for Parkinson's disease, but not very sensitive for multiple system atrophy. There's much less fluorescence. So it's a little tougher to detect the patients with multiple system atrophy. Having said that, though, and this is from the paper that was published about 5 years ago, we were able to see that you could use this misfolding, this prion-like misfolding in patients with Parkinson's disease to detect the misfolded aggregates, and their sensitivity was 88% and their specificity was 96%. And then this was the paper that was published last year. Now, one of the things that they did in this paper was that it was only patients with Parkinson's disease. And all of the patients, in order to get into this study, had to have an abnormal DAT scan. By the time you have an abnormal DAT scan, you've lost about 50 to 60% of the neurons in the substantia nigra. So these are patients that were fairly far advanced in their Parkinson's disease. They also looked at whether or not the patients were losing their ability to smell, so their olfactory sense. So what they found was that overall, the sensitivity was 87% and the specificity was 96%. But if you looked at the patients that didn't have a loss of smell, then the sensitivity was actually only 78%. It was significantly lower. So where this really worked was patients that had an abnormal DAT scan and had abnormal smell. Then we could detect it with the seeding assay quite well. But again, it still required a spinal tap. So there was sort of a desire to say, is there a way to look for this alpha-synuclein protein in a less invasive way? So the limitations to the SAA, again, is lower sensitivity for biofluids other than the spinal fluid. You can't quantify it. So it's really just, is the bad protein present or is the bad protein not present? It takes days and days to do the test, so it's very labor intensive. And standards between the labs vary quite a bit. And as I said, it's not very helpful for multiple system atrophy. So we began to look for, again, another way to detect this abnormal alpha-synuclein protein. And we began to look in the skin as being a potential source to look for these abnormal proteins. So right now, if we think about the diagnosis of Parkinson's disease, the diagnosis is obviously predominantly clinical. But that leads to a lot of misdiagnoses because we don't have a specific test that allows us to tell us this is Parkinson's disease versus perhaps another Parkinsonian disease. We do have some genetic tests that can be abnormal in about 10 to 15% of patients. We can order the DAT scan, and then we'll talk today about the skin biopsy, and also the seeding assay is available as well. But having said all that, we still know that our clinical diagnosis is not great, and so all of the recommendations are that you have to evaluate the patient every year and make sure that we still believe the diagnosis that we came up with is the correct diagnosis. This is just some data to show you how bad we are at making a diagnosis of Parkinson's disease. So these are autopsy studies, so that would be the gold standard test to prove the diagnosis. And so on the left, we had 131 cases that were diagnosed as Parkinson's disease. When they came to autopsy, the neurologists were only right 68% of the time. And on the right side of the screen are patients that were diagnosed with other forms of Parkinsonism, and 12% of the time it actually turned out to be Parkinson's disease and not another Parkinsonian disease. So we're not great at this diagnosis. These are similar autopsy studies done in patients with multiple system atrophy. And what you can see again on the left study was 203 patients. We were right 78% of the time. And on the right side, 134 patients where we were right 62% of the time. I like to tell my students and residents that if I tried to get through medical school being right 60% of the time, I probably wouldn't have gotten through medical school. But this is the best that we can do right now. So let's talk a little bit about alpha-synuclein. Alpha-synuclein was discovered in 1988. It was discovered because they had made an antibody trying to target this protein. The antibody actually stained both the nucleus and the synapse, and so it was given the name synuclein for synapse and nucleus. Once they actually discovered better antibodies, it turned out that was wrong. It doesn't actually stain the nucleus at all. There's no synuclein in the nucleus. The synuclein is only found at the synapse. So it actually is kind of a bad name for the protein, but the name has stuck. In 1997, the first genetic mutation for Parkinson's was discovered, and that was the alpha-synuclein gene. So just about any mutation in the alpha-synuclein gene will lead to an autosomal dominant form of Parkinson's disease. We don't actually know the function for the alpha-synuclein protein. We think it's involved in neurotransmission because it's present at the synapse. And the current theory is that actually it slows down neurotransmission. So it sort of puts the brakes on the release of dopamine, but we don't know that for sure. The concept that we have now is that the protein is translated into a protein, and so it has its normal unfolded shape. And then like all proteins, it has to fold and become the thing that it's supposed to be, and therefore do its normal function. But if something causes that protein to misfold, then it becomes like a prion protein. Now, it's not a prion protein, so you can't transmit Parkinson's disease from one person to another the way that you can transmit Jakob-Creutzfeldt disease. But we believe that the one misfolded protein will cause other proteins to misfold. And then that builds up and builds up inside the neuron and eventually damages the neuron in the form of a Lewy body. If you look at the bottom pictures, you can see Lewy bodies, and I want you to focus on the bottom right picture. That's a Lewy neurite. So when we talk about Lewy bodies, we're talking about large accumulations of the proteins, alpha-synuclein, ubiquitin, other proteins as well. The Lewy neurite is the abnormal protein in the axon. And the reason I want you to kind of look at that is I'm going to show you some pictures from the nerves in the skin, and they're going to look very similar to that. So we think we can actually identify Lewy neurites in the skin using this new technology. Now, Parkinson's turns out to be really fascinating because it is a very slowly developing disease that develops over many, many years. So if you look at the time zero, that would be when the person has all the clinical features of Parkinson's disease. But if you go back 5, 10, or 15 years, you start to discover that these patients have many symptoms that are very characteristic. So one of the earliest symptoms is actually REM behavior disorder. So patients that act out their dreams. And that can happen 10 or 15 years before. But we know that if you have REM behavior disorder, you have about a 70 or 80% chance of developing one of these diseases. So either Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy. So we think it's prodromal for these patients. We know that we can detect the abnormal protein in patients with REM behavior disorder already. So that means that, again, 10 or 15 years before Parkinson's, this protein is starting to build up already inside their nerves. We also know patients can have a lot more constipation, and that was one of the reasons that we were very interested in the skin, because we think that the constipation is coming from involvement of their autonomic nerves. And we have a lot of autonomic nerves in the skin that are very easily accessible. And then they start to lose their sense of smell, and they develop depression, anxiety, and then they start to develop bradykinesia, and eventually all of the symptoms. So really, this is a disease that's developing over many decades. The exciting thing about that is that if we could identify these patients early, we actually might have the ability to try to intervene in these patients. So I mentioned why talk about the skin if we're talking about a nervous system disease. And the answer is that there's a lot of nerves in the skin, and in particular, a lot of nerves related to the autonomic nervous system. So if we think about patients with Parkinson's, they have orthostasis, they have constipation, they actually get dry skin more often. They get more skin conditions like keratitis as well. So something seemed to be going on in the skin that told us that those nerves in the skin may actually be very relevant to this disease. So we can take a very small little biopsy, so the top picture is showing you just kind of how small a piece of skin we need, and we can then analyze that skin. And on the bottom right, what you see is the way that we analyze it. So we use a stain that will stain all nerves. So the green is looking at all the individual nerves in that nerve bundle. The red is a stain for the abnormal form of the protein. So we call that the phosphorylated alpha-synuclein. Like in Alzheimer's disease, when you add more phosphorus groups on, the proteins start to misfold. So we're looking at the misfolded form of the protein. And then we merge those two images together where you see the orange or the gold. And that tells us the abnormal protein is contained within the nerve. So this was a study that we just published, actually just last month. This was a study funded by the NIH. And what we looked at was 30 different sites across the U.S. We did this in a prospective, blinded way, where we took 3 biopsies from each patient. And we wanted patients that had either Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, or a 4th disease called pure autonomic failure, which is another disease caused by alpha-synuclein. The patients met the consensus criteria, but then we had a blinded panel that reviewed all the clinical information to see if they agreed with the diagnosis. So we still didn't have autopsies, which would have been the best test, but by having 2 different steps to try to review the clinical diagnosis, we felt we got as close to the true diagnosis as we could. Again, this is the pathology on the left. So we had 428 subjects in the study. We had 108 Parkinson's patients, 69 multiple system atrophy, 67 with dementia with Lewy bodies, 33 with pure autonomic failure, and then 150 healthy controls. Better. Those patients then all underwent the blinded review. So the panel reviewed all the clinical information on the patients. 343 were kept in the original buckets, and about 20% were moved because they didn't fulfill all of the criteria. Yeah, perfect. Yeah. So 20 were removed. And that sort of fits with what we'd expect because, again, if you do autopsy studies, about 20% of the patients will be misdiagnosed. So that tells us that 20% of these original patients were misdiagnosed. And this is the data from the paper. So the take-home messages were, if you combined all 4 of the abnormal synuclein diseases, of 223 patients, we were able to detect the abnormal protein in 213 of them, which gave us a sensitivity of 95%. And then the specificity was derived from the healthy controls, and of 120 healthy controls, 116 were normal, and 4 had the abnormal protein. When we looked at those 4 patients, they actually had some symptoms, so they had a little bit of orthostasis or other symptoms that could suggest that they were very early in the disease process. So we're not sure. We're going to continue to follow those patients. And then you can see the individual groups. So in Parkinson's, our sensitivity was 92%, multiple system atrophy 98%, dementia with Lewy bodies 96%, and pure autonomic failure was 100%. Pure autonomic failure is more of a peripheral disease, so it makes sense that there was actually more alpha-synuclein in those patients. The other thing that we found was that the amount of the abnormal protein correlated with the disease severity. So again, as a biomarker, you want not just to know this is present or not present, you also want to know, does it give us some prognosis? Do we understand something a little bit better about the disease by studying these patients? And so what we found was that the more phosphorylated synuclein that was deposited, the lower their cognitive score, the lower their quality of life, the longer they had had the disease, the more orthostatic hypotension they had, the more symptoms of REM behavior disorder they had, and then the higher their motor symptom scores. So we looked a little further at this group as well, and one of the ways that we did that was by looking at patients that had the dementia with Lewy body group, as well as patients that had mild cognitive impairment. So when we recruited our healthy controls, we actually just put an advertisement in the paper, and we had people come in, and then they went through all the scales. So there were a number of people that came into our study saying, I'm healthy, but when we did their cognitive scores, they were not quite as healthy as they would like to be. So we looked at 67 patients with dementia with Lewy bodies, the same 151 healthy controls that went through the expert review. We found that of these 67, 50 met the criteria. That's the 50 that I showed you before. We found new patients, 26 of them, that had mild cognitive impairment based on their Montreal scores. And then we had 120 that were truly healthy controls. And when we looked at these patients, it turned out that there were a number of interesting findings. The first was that age tended to track with the disease severity. So the youngest was in the control group, the mild cognitive impairment a little older, and then the dementia with Lewy bodies a little older than that. And then if we looked at the positivity, so in other words, how often we found the abnormal protein, again, 96% of the dementia with Lewy bodies, only 3% of the healthy controls, but in the mild cognitive impairment group, we found 30% of those patients that had the abnormal protein. So again, suggesting that these patients, who we now need to follow them longitudinally, but these patients may be developing dementia with Lewy bodies, the other 70% probably developing other forms of dementia as well. And then we could quantify the amount of the abnormal protein, and that tracked with the severity of the disease as well. So in the healthy controls, basically there was no synuclein. In the mild cognitive impairment, a score of almost 2, and then those with the dementia with Lewy bodies, a score of 8. Again, suggesting that as the disease progresses, there's more misfolding of this abnormal protein, and that you can detect that through the skin biopsy. This is just another example of the way in which we can quantify the protein. So here's a section of the skin. On the left, that rim is the epidermis, so it's the outermost layer of the skin. And then as you go deeper into the dermis, we use a computer software system, and the computer software system now can identify the nerves, and it can identify the abnormal protein. So it's picking out these nerves here that contain the abnormal protein, and then we can now quantify the amount of that protein. So as we move, and we're doing some work with pharmaceutical companies, as we move towards interventions that might target this protein, we may have a way for us to detect if we're lowering the level of the protein inside the nerves. We talk also about what we call a synuclein signature. So each of the 4 diseases actually have slightly different presentations. So the size of the circle here dictates how much synuclein is present. So you can see in dementia with Lewy bodies, big circles present in all 3 sites. The mild cognitive impairment group, smaller circles, again, less of the synuclein that we can quantify, and then the healthy controls. The other interesting finding is that when you look at these nerve biopsies, there are sensory nerves in the surface of the skin, what we call unmyelinated nerve fibers. And those actually seem to deteriorate as a result of this condition. So these arrows indicate how much nerve loss there is. We see this in Parkinson's disease as well. And one of the arguments for the sort of restless feeling that patients with Parkinson's have may actually be that there is some sensory neuropathy that's going on as well in those patients. So in conclusion, we think that the skin biopsies are a very simple procedure, very low risk. It doesn't require any stitches. You just put a Band-Aid over the site. And it provides a very excellent diagnostic biomarker for the detection of phosphorylated synuclein. We do the fluorescent immunostaining, which can give us very high sensitivity and specificity across Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, and pure autonomic failure. And we can use those signatures that I showed you to help distinguish between the different synucleinopathies. We think this can help a lot in clinical trials so that we can be sure we're enrolling patients that have the right disease. Again, if there is about a 20% misdiagnosis rate and we're putting people into clinical trials that don't have the disease, we're never going to find effective therapies. And the ability now to quantitate the amount of synuclein can help detect if we're actually making an impact on the patient's disease course. We see it in patients with dementia with Lewy bodies, but we're also seeing it in patients with mild cognitive impairment. And the reason that's important, again, is that if we're ever going to really truly intervene in these diseases, we're going to want to detect the protein as early as possible. So we don't want to wait until somebody has all the symptoms of Parkinson's disease or all the symptoms of dementia with Lewy bodies. We know these diseases are evolving as they go from healthy to mild cognitive impairment to dementia. And the earlier we can detect that, the better. So we are doing now 2 other large studies funded by the NIH, one to look at patients with mild cognitive impairment and one to look at the patients that have that REM behavior disorder to see how early we can detect these proteins. And I think that's all I have. Yep, just to thank everybody who helped with the studies.
Thank you, doctor. We have some questions. Yo. Vamos a tener traducción por parte de la compañera. Okay. ¿Puede hacer la pregunta en inglés o en directo?
Thank you very much, Dr. Levine, for your presentation, and feel welcome to Mexico. Yes. I have 2 points. The first one is, with this evidence, is there any position for the Movement Disorders Society about to use this evidence as part of the diagnosis of Parkinson's disease, for example, or whatever? And the second one, I haven't seen anything about corticobasal degeneration, identifications with the tau proteins. I would like to have some comments from you. Thank you very much.
So the Movement Disorders Society has not yet come out with a position statement. The seeding assay was just last year. Our paper was just this year. So we think it will probably come. What they have come out with is 2 position papers on what they call the biological definition of Parkinson's. And so the idea is now not just looking at the clinical picture, but really looking at 3 features to come up with this biological definition. So one feature is the presence of phosphorylated synuclein. Now, you could look for that through the spinal fluid, you could look for that through the skin, and they hope someday to be able to look for that in the blood, because that would be the easiest. Right now, the 2 options would be the spinal fluid or the skin. So one part of the biological definition is this Parkinson's disease with synuclein or Parkinson's disease without synuclein? And the reason that's important is the second piece is the genetics of the patient. Because we know that some of the genetic forms of Parkinson's disease don't have Lewy body pathology. So you have the protein piece, you have the genetic piece, and then a neurodegeneration piece, which would be SPECT scans or DAT scans. So they're trying to put patients with Parkinson's disease into smaller groups and not lumping them all together, because people progress very differently. So I think that we're going to move towards this kind of biological definition. Right now, in the US, people I think are using this for really one of 2 reasons. One is you're confused about what the patient has. So they look Parkinsonian, but maybe they don't respond to levodopa. And you think about a tauopathy. So doctors are definitely using it to say, okay, this patient looks Parkinsonian and has abnormal alpha-synuclein, therefore it's much more likely to be Parkinson's disease. Or this patient looks Parkinsonian, doesn't have alpha-synuclein, and therefore I should think about PSP or think about CB, cortical basal syndromes. So I think it's used that way. Recently, so we've been offering this test commercially in the US for 4 years, and it has begun to be used a little bit earlier. So doctors see a patient, they think that patient has Parkinson's disease, and they'd like to have some kind of confirmation, something that's objective that allows them to say, I'm more confident in my diagnosis. So we originally thought it would mainly be used for those tough cases, but it's being used a little more earlier now in the disease. And we are doing work now to look for tau, so we'd love to be able to find tau as well, to look for the cortical basal syndromes and PSP. It's not yet available, but we are doing some research on that. So right now it's really to rule in alpha-synuclein or rule out alpha-synuclein.
Other questions? Otra pregunta? It's okay? Okay, it's okay. Dr. Levine, thank you very much. Okay.
Hi, doctor. Welcome to Mexico.
Bueno.
Hi. I only have one question. What is the difference between the cost of obtaining these biomarkers from the cerebral fluid and the skin biopsy? Where is more or less the cost?
So it's about the same cost. The difference is depending on who, I'm not sure how you all do. So in the US, sadly, neurologists don't really do spinal taps anymore. So most neurologists in the US will send to radiology and let the radiologist do the spinal tap. So the procedure for acquiring the spinal fluid in the US is much more expensive than the procedure for acquiring the skin biopsy. Because the skin biopsy is just done in the doctor's office. The test itself is about the same price and is much, much less than a DAC scan. So I think a lot of we're in fact getting ready to publish a paper where a lot of neurologists in the US now have really stopped using the DAC scan and have begun using the biopsy instead, because it's easier, much faster for the patient. You know, a DAC scan takes 4 or 5 hours for the patient to do. This takes 10 minutes. So it's very simple. So if you eliminate the cost of the procedure, it's about the same price between the spinal fluid and the skin, but cheaper than the DAC scan. Now, do you all do your spinal taps yourselves?
Thank you. It's me again. There were some attempts to identify alpha-synuclein on saliva.
Yes.
Yes. How's the position right now? And because it's quite easy. Yes.
An easy procedure. It's a little more uncomfortable for the patient in terms of just recovery, but not terrible. And the sensitivity is also fairly high. So the question was